This last section deals with the treatment and management of long QT syndrome. It is particularly important because if you make mistakes, your patients can die. So we as physicians have a major responsibilities in dealing with how we treat our patients. We can make a mistake in interpreting a genetic finding. We may miss the measurement of the QT interval, but we cannot fail when we decide how to treat and manage our patients. One has to look at the beginning, and in the beginning there was a great confusion. Until the mid-70s, as you see here, there was a huge variety of treatments that were used for the long QT syndrome. Whenever you see anything like that, the implication is one: the physicians did not know what to do. This letter was sent to me in 1972. I was 29 years old at the time, and the letter came from Professor Conor Ward. Professor Ward is the one who described what has been called the Romano-Ward syndrome, which is the long QT syndrome without congenital deafness. In answer to a question of mine, he writes the following: "Unfortunately, the patient who was maintained free from attacks on a combination of carbamazepine and phenobarbital for 1 year subsequently had a single fatal attack. Dürer," and Dürer is of course Professor Dürer, one of the pioneers of clinical electrophysiology in Europe. Dürer in Amsterdam has been observing another patient, and when I last spoke with him, he was pessimistic about controlling the condition in any way. Digoxin shortens the QT, but does not prevent attacks. And indeed, in those days, a lot of patients were treated with digitalis and they all died. It may be, he continues, that the remission we had with phenobarbital and carbamazepine was due to their combined sedative effect rather than to any specific cardiac action, and I believe that he was completely right. This sentence is something that we all would agree with at this point. Beta blockers at full blocking dose represent the therapy of choice and are greatly effective in reducing the mortality. This is exactly what I wrote in 1975, when I connected the disease and the manifestations to a sudden increase in sympathetic activity, which was the combination that was leading to syncope, cardiac arrest, and sudden death in these patients, either brought about by a sudden fright, a sudden emotion, fear, or strenuous exercise. As time evolved, there was a question on whether or not to treat asymptomatic patients. And in 1985, Art Moss and I were still thinking that asymptomatic patients might have not needed beta blockers for life, and we were not recommending it. We were wrong. As it happens often in science, you have to wait to see if you were right or wrong. In this case, we were badly wrong. As you see from this slide, out of this relatively large number of patients, those who died or had a cardiac arrest as a first event are not a small percentage, 12%. Even more important is the fact that out of the patients who died, 68%, 2/3 of them, actually had their lethal event as a first event. It was the first manifestation of the disease. This means that with the long QT syndrome, there is no room for error. We cannot wait for a first episode to initiate therapy, as we rather naively were thinking in the early 80s. We've got to treat everyone before something bad really happens. This slide shows you the situation we had in 1985. We were able to compare 233 patients who all had a first syncope, which we defined as time zero. Where you see the arrow, you see what happened to the patients that were either not treated or not receiving beta blockers. 21% of them died within 1 year from the first syncope, and at time zero, their average age was 14 years. So we are talking of children, young adults, with a 21% probability of dying within 1 year from the first episode if they are not treated properly. And as you see, mortality goes on unabated to reach 50%. By contrast, in 1995, the patients treated with antiadrenergic measures, be they beta blockers or left sympathectomy, had a much better prognosis. And this has changed a lot now, because in 2019, patients treated with either left sympathectomy or with beta blockers have a mortality less than 1%. The traditional therapies include beta blockers, left cardiac sympathetic denervation, ICDs, and mexility. I will say just a few words about each of them, and then I will say something about the new therapeutic options, which mean gene-specific management and moving toward precision medicine. Let's talk first about traditional therapies. As beta blockers go, I think it's important to keep in mind that not all beta blockers are equally effective. Specifically, metoprolol should not be used for symptomatic LQT1 and LQT2 patients. The most effective beta blockers are propranolol and nadolol, and nowadays nadolol is a drug of choice. This is exemplified in this slide, where you see that the recurrence of events on metoprolol therapy is markedly higher than what happens for patients treated with either propranolol or nadolol. For a number of years, there was a misconception that LQT3 would not respond well to beta blockers. This was simply due to the fact that with very few patients, all studies were lumping together adults and infants with long QT syndrome type 3 and symptoms. We learned at one point that LQT3 infants symptomatic are a group at extremely high risk, very difficult to protect. Very different is the situation for adults treated with beta blockers. And the study by Wild et al. Performed in over 400 such patients, of whom 111 were on beta blocker therapy, showed that there were 7 deaths, but 4 had a cardiac arrest in the first year of life. If you look at the mortality for LQT3 patients on beta blocker therapy without events in the first year of life, mortality was below 3%. The take-home message is that all long QT syndrome patients should be treated and protected with beta blockers. Left cardiac sympathetic denervation is something I've been using since 1973. And in the 70s and 80s, I performed a large number of experimental studies to understand how it was working and what were its main effects. This is a list of our results. Left cardiac sympathetic denervation reduces the release of norepinephrine at nerve endings, and that's one of the mechanisms of action. It reduces arrhythmias associated with myocardial ischemia. It increases ventricular refractoriness. It raises the threshold of ventricular fibrillation. This is an extremely important point. I will return to that in a moment. It increases the myocardial reactive hyperemia, which is an index of the capability of coronary bed to dilate, and that is why it is useful also in ischemic heart disease, and does not affect cardiac performance during exercise. This is a figure from my original paper in 1976 on left sympathectomy, where it shows that left sympathectomy increases the threshold for ventricular fibrillation by over 70%. This means that it is more difficult for a heart to fibrillate when the left sympathetic nerves are no longer in place. The conclusion of our study in 1976 was that to raise the ventricular fibrillation threshold without drugs in patients at high risk for ventricular fibrillation is a rational approach to the effort of preventing sudden cardiac death. And this is why nowadays left sympathectomy and sometimes bilateral sympathectomy are explored to prevent sudden death in a variety of clinical conditions. Our last study in long QT syndrome patients was performed on 147 deemed to be at extremely high risk for the following reasons. 99% of them had symptoms, with 48% of them having survived a cardiac arrest, 75% had recurrences despite beta blockers. Their QTC was extremely long, an average of 543 plus minus 65. If you check all populations with long QT syndrome, the average QTC is usually between 490 and 500. So these were patients with an extremely long QT. The 5-year cumulative mortality was only 3% in this extremely high-risk population. I wish to call your attention on another issue. In that study, there were 5 patients in whom sympathectomy was performed after implant of an ICD, and the reason was that this poor patient kept having multiple shocks. As a matter of fact, the follow-up time between ICD and sympathectomy was only 17 months. The follow-up after sympathectomy was 4 years. Look at this number, 29. This is the number of shocks per patient per year before left sympathectomy. Try to imagine to have a child, your own child, 15-year-old, having 29 shocks per year. It's a dreadful thing. What happened to these patients after sympathectomy is that there was a major reduction, only 3.3 per year, and they were all in one patient because 4 of them went down to 0. So there was a reduction of 95%. In these 5 patients, left sympathectomy did not save their lives. That was taken care of by the ICDs. But their quality of life and the quality of life of their parents changed in a very dramatic way. Left sympathectomy is now recommended in the clinical guidelines. And this last one, the guidelines of 2018, write that sympathectomy, left sympathectomy, is recommended for high-risk patients with a QTC greater than 500 milliseconds or with syncope despite beta blockers. Personally, I believe that to implant an ICD in these patients without trying first left sympathectomy is no longer justifiable. Let's now turn to the ICDs. The largest study performed in long QT syndrome who had an implanted ICD is this one, published in Circulation in 2010. We had 233 patients. The average follow-up was 5 years. What you should be looking at is the incidence of major adverse events, 31%. If you keep in mind that these are primarily young patients, that within 5 years from their implant, 1/3 of them have significant adverse events, you realize that this is not a free lunch. we have to be careful when we implant an ICD. We do it all the time, but we do it whenever we think that the patients are really at very high risk. The logical candidates to ICD implant are, of course, the survivors of cardiac arrest on therapy. Many of those who survive the cardiac arrest of therapy, with few exceptions, patients with syncope on beta-blocker therapy when left sympathectomy is not available, or patients with syncope on beta-blocker therapy who have two mutations, primarily the Jervell-Lange-Nielsen syndrome patients, and exceptionally asymptomatic patients with a QTC greater than 550 milliseconds and electrical instability. In other words, I think that we as physicians should keep to ourselves the privilege to decide if we are dealing, even if we are dealing with an asymptomatic patient, with someone at such a high risk to warrant the implant of an ICD even before a first event. This sentence comes from the review article that I published with Mike Ackerman, and I wish to share it with you. Currently, there is a stunning mismatch in ICD utilization for patients with LQTS syndrome, with some programs in the United States implanting an ICD in almost 80% of their patients with LQTS, while among two of the largest LQTS syndrome clinics in the world, our ICD utilization rate is 10-15%, that's Mike Ackerman, and 3%, and that's me. And our mortality is actually below that of most other centers. A few words about mexiletine. As I pointed out earlier, we began to use mexiletine already in 1995 in the patients with LQT3 mutations because we knew that they had an excess inward sodium current. This slide I've already shown and is the one that has led to what is now widespread use of mexiletine for LQT3 patients. This is one of the best examples, of course, that we had. A 17-year-old kid with LQT3, under propranolol, his QTC exceeds 500 milliseconds. When we added mexiletine, it was completely normalized. Very recently, with Mike Ackerman and his group, we were able to show that mexiletine is able to shorten the QT interval also in LQT2 patients. Our data are limited in number. They suggest that a positive effect can be achieved in approximately 2/3 of them. This is one of our examples. A policewoman who had a cardiac arrest confronting bandits. Her basal ECG was showing a very long QT interval. After mexiletine, it was practically normalized. Her follow-up now is 3-4 years. She never had anything else. What we recommend is to test mexiletine with the acute oral drug test, which takes only 2 hours, and within 2 hours you know if the patient is a responder. If it's not, there is no need to start chronic therapy. Let's end with a look to new therapeutic options. They are mostly the consequence of our understanding of what happens according to the various genes that are implied in the disease. This study was critical in that regard. In 2001, we were able to obtain information on almost 700 patients, of whom we knew the genotype and all had cardiac symptoms. This slide relates to the triggers for lethal cardiac events, cardiac arrest and sudden death. We examined 3 conditions primarily: exercise, emotion, and sleep or rest without arousal. You see that for LQT1, 90% of the individuals had their lethal events triggered by either exercise or emotion. Conversely, if you shift to the right and look at LQT3, you see a profound difference. In this case, 80% of the individuals had their events while they were asleep. The two arrows show you that LQT2 and LQT3 patients are at very modest risk during exercise. The reason is actually pretty simple. These two groups of patients have an entirely normal IKS current. So whenever they exercise, they are able to shorten their QT, and they don't die while running, but they die under different conditions. There are indeed specific triggers. For LQT1, swimming seems particularly important, probably because of the combination with exercise and cold water, which increases sympathetic activity. For LQT2, auditory stimuli are particularly important. By auditory stimuli, I mean an alarm clock waking up people in the morning, a parent entering in the room yelling, "You're late to school," or a telephone ring. For these patients, one has to think about what is the trigger. The following recommendation are the results of our understanding of the triggers that initiate the life-threatening arrhythmias. For LQT1, they should limit as much as possible strenuous exercise, especially under condition of increased emotional activation. Swimming should be allowed, but with supervision. And by supervision, I mean the supervision of an adult who can swim. If an adult cannot swim, that's totally useless. LQT2 patients are exquisitely sensitive to low potassium, so their potassium level should be monitored and preserved in an adequate manner. One should avoid loud noises for them, alarm clocks and nighttime telephone in the bedroom. In treating LQT2 patients, we always administer beta blockers twice a day, morning and evening, because in this way we maintain an adequate plasma level in the morning. For LQT3, there are questions about the possible value of keeping in the house an automatic external defibrillator because it's in the house that they tend to die more often. There is also a question about bedroom sharing. The transition between torsade point ventricular tachycardia and ventricular fibrillation in a patient lying in a horizontal position is rather long. This allows for a progressive loss in oxygen perfusion at brain level and for the onset of agonal sounds. They may wake up someone sleeping in the same bed or in the same room and allows time very often for resuscitation. So that's something to be considered. What you just heard refers to the progress based on the possibility of gene-specific management. But we are moving toward a different level. We are entering in the time when it's going to be possible to make mutation-specific therapy, what is called precision medicine. These are complex studies that are evolving right now in many laboratories, including our own, but it would take too much time to discuss it at length now. Just follow the literature and you will see what's happening. These three papers listed here are my recommended readings. I think they will help you to manage better your patient. I hope you'll do well. Good luck with your long QT syndrome patients.